We're going to welcome back our live stream people, and I'm sorry that my back was to you all morning. Sorry about that. I hope the morning was great for our live streamers, and if you happen to walk by, you can say hello to our folks from around the world that are joining us remotely. So this is open Q&A, so all the questions that you didn't have the chance to ask in the other sessions, or if you wanted to ask one of the other physicians a question that you were not part of their session. And we've got our two lovely mic runners over there. I'm going to hand this mic over to Tina in a second. So Tina, you want to do me a favor and come over here? So we're going to have Bridget on that side. So if you have a question, you're going to raise your hand and you're going to give her 2 seconds to get the mic to you, because then everybody can hear your question and everybody on the live stream can hear your question. And then Tina's going to take this side of the room. Sound like a plan?
Susan?
Yes, ma'am.
I think there were other physicians.
No, just us.
Okay.
Dr. Piet, I think he had to, did he leave? He had to leave this morning, so yeah. Sorry, you know, when everybody has busy practices and they see, we have you guys, well, you're local, but you're not local, so she's stuck with us for the rest of the day, a captive audience. So we capture them and keep them here. So let's ask this question. Who wants to ask the first question? And if no one wants to ask the first question, I will ask the first question. But I know we've probably got someone in the audience that has a burning question. Sally has a question. Excellent. So I'm handing the mic to Tina now.
We've heard a lot about drugs this morning. Mm-hmm. Can you please tell us what lifestyle changes can help build back the immune system?
Good one. I think Marianne should take that.
That's the nurse. So
It's a
lifestyle.
good question.
Yeah.
Actually, that's a very important.
Yeah, it
I
is.
have my version.
Yeah, I was going to say, I think it's a great question because I think of the immune system and lifestyle as sort of kind of, you know, matching up hand in hand. So a couple things that I think are helpful, nutrition. And if one happens to be in a setting where you have access to a nutritionist, even just having a consult ×1, just to have an understanding of what you're taking in, are you supplementing, I think that's really important. I think exercise, no matter what, particularly a lot of the therapies that we use for this disease, if we put patients on bexarotene or targretin, we're dealing with maybe a lipid issue that they never had until we imposed a therapy upon them. So exercise would certainly help in that setting. And then stress reduction, I think, is huge. And by whatever means one finds that they can do that, whether it be yoga or, you know, Reiki or, you know, whatever, I think that all of those spheres need to be addressed. Others?
Yeah, I just wanted to reiterate that I emphasize with my early stage patients just having a very balanced lifestyle, focusing on the diet to be healthy the way it generally should be. And generally with my more advanced stage patients, I will definitely send them to a nutritionist to sort of do calorie counting and making sure they're getting enough of the calories they need and the right types of calories. So exercise being very important to addressing it by stage. So I definitely don't want my advanced stage patients going out and trying to run a marathon, but doing something that helps you to build muscle mass and to stay as healthy as you can. So.
I actually don't have much to add. I think what my colleagues have said is exactly, there is no magic thing, diet that you should do more of, but it's the general balance and nutrition and exercise. We emphasize that a lot, that it's not a specific thing that you could do more of, but it's the general health and nutrition and exercise.
Well, thank you. I guess this is kind of a personal question. I've only had this, or been treating this for about 2 years, MF. And I guess my question is, how important is it to get a PET scan and blood test and consultation with a hematologist if so far biopsies and the blood test I've had recently show nothing in addition, no symptoms of anything but, the itching from this. I feel fine, and it'll be expensive. This stuff is expensive because everything I've inquired about says that Medicare just ignores CTCL. I guess my question, therefore, is how important is that really? It's a personal dilemma that I have.
So it very much depends on your individual evaluation. So, and where you're located and where you're seen. So I would say if you're closer to a larger university center, we definitely like to see our patients there. And it'll depend on your individual physician's expertise in the local area you're in and how much they know. Generally with very early stage patients, like stage 1A patients, I typically don't require a PET CT, and some of the finer blood tests I don't think need to be done. We just do screening tests that may already be available from what your primary care doctor or general dermatologist has done. As this disease advances for other people or they have advanced stage disease, those blood tests can be different, and those PET CTs can be much more important in determining what we do. So it definitely is dependent on the individual person and where their stage of disease is at. Because I do monitoring very differently for a stage 1 patient than I would for a stage 2, 3, or 4 patient. So, sorry, not probably specific to what you're asking for yourself, but it's dependent more on stage. So,
Yeah, I would agree with that as well. We tend to think about getting blood tests again or getting PET scans again if the patient demonstrates that their disease is misbehaving. So if your disease was in a steady state, you were worked up, we have a stage, and you're responding appropriately, then we don't go looking for problems. We don't go searching the blood or doing PET scans. But if your demonstration of your disease changes over time, we would become suspicious and might look at the blood again or look at a PET scan again. And certainly that's different for patients that maybe partake in clinical trials. That might be a time before embarking on a clinical trial that we would relook at them again. But if everything's behaving and you're responding, then serial studies are not typically warranted.
Yeah, just echoing that, especially if you're early stage, there's really no reason to even do surveillance scans unless there's something changing. And fortunately, the lymph nodes that are involved in the MF and Sézary are peripheral lymph nodes, not central. So in this cancer, you could, if you do a good physical exam of the lymph nodes, that's at least a good screen. So you don't have to, in case there's a surprise. But if you're doing really well, you're early stage, we don't do surveillance imaging or not even Sézary. But if you, as my colleague said, if you have more advanced disease, so then sometimes you're at more risk of developing, and then you may periodically do one, especially if your disease is not well controlled, and if you feel something that's concerning.
Yeah, that's helpful. You said the term surveillance imaging, which I think is what my doctor wanted to do or suggested. So that's kind of
right.
what
So early stage, yeah, we would not do that if you're doing really well. Because the reason we say that is we used to do that all the time, and now the trend is not to do unnecessary imaging. So not in our just space in our disease, but all the other lymphomas, the trend is to do less. So if we can feel lymph nodes and we could detect some obvious changes in the blood, or in the patient, the disease may not be well controlled, but in absence of any of those, there's no reason to just go do a scan.
Yes. Well, thank you all. That's been very helpful.
See, I thought he was here.
We have 2 questions from online.
Thank you, wonderful panel. This first question comes from our online friend Silver 143. She was diagnosed in March of 2015 with mycosis fungoides. Had it for about 27 years without her knowledge. Just had 2 biopsies at a hospital in Cleveland. This is addressed to Dr. Kim, I believe. You were talking about, her doctor was talking about starting Valcalor, but did not explain what it was during the appointment. In your expert opinion, Dr. Kim, can I wait another 2 years for new options if the cancer keeps growing slowly? About 8% body coverage patches. I'm trying to put off treatment as long as I can, which may not be a good thing. And she did have a biopsy and a blood test when first diagnosed.
So to summarize, it looks like the caller has mild, very limited disease, less than 10%, maybe patch. I would say, inconsistent with the guidelines, the treatments are definitely skin treatments, so there's no evidence you should do more than skin. And your common choice are the topical steroid. And I don't know if the caller had that done already. If the topical steroids, we usually start with topical steroid in very mild disease, but if the steroid doesn't cause prompt response, like clearing, or if it just causes stable disease, then we'd like to switch, because I don't want to cause chronic steroid-related atrophy. So we would use Valclor or nitromustard topically would be a common choice. If you have it more widespread, we may think about phototherapy, but the topical options are easy to use, so that would be a reasonable choice for them to use. There's other topicals like Bexarotene and Imiquimod, but they can cause a little bit more skin irritation. So if the steroids are not working, then Valcor would be a good option. But
And it's safe.
yeah, it's safe. I'd like more into.
Oh, I think the thing is the Valcor is chemotherapy, but the main risk is irritation or a poison ivy-like reaction that some people get, and there are ways to desensitize to that. So it's there's little harm in using it. If it doesn't help within a short period of time, you can stop. If you have irritation, you can stop. But in general, we think if we have a treatment that doesn't bother people very much, that can reduce the burden of disease, it's probably a good idea. The longer you wait, the more cells there are, the more one of them may mutate in a way we wouldn't like. So if we have an easy way to reduce the cell burden, it makes sense to try it. Do you agree with that?
Oh, yeah, that's true.
Oh, okay.
We have another online question. Our online friend PMI asks, I have just been diagnosed with MF by a dermatologist who says, don't worry, you'll die from something else. Always a great message to hear, I don't know. Who would I consult with next? Another dermatologist, a hematologist, an oncologist? I believe I am stage 1A. What tests should I have to determine my status, and what treatment should I consider? The only treatment prescribed is fluocinolone cream with no instructions for use or duration. Lots of good questions.
Thanks. So with stage 1A, it is slow growing and it does have a good prognosis, but I think as Dr. Piet pointed out, if we can do a simple treatment that's topical, that doesn't cause side effects, it is important to get rid of those cells if we can, because we don't know if one would ever arise and mutate. While we tell most people that they're going to do fine, we do like to treat, because we don't know if you'll be that one person that prognosis does not remain true for. So fluocinolone, a topical steroid, is, as Dr. Kim said, is one of the first-line treatments that we start with, and should be applied to the skin once to twice daily. I do it for as long as somewhere between 8 to 12 weeks, but that's depending on how thick we're dealing with. So if you're dealing with a patch, that's thin, you can't feel it, but you can see it, I probably wouldn't do it for that long. But if it's a plaque, then I would probably go for that length of time, following along closely to see if we need to change therapy. So, and the side effects, as Dr. Kim also referenced, are your skin can get addicted to it. So it means that if you try and stop using the medication, you may get more redness. You could get thinning of the skin. You could get little blood vessels that develop in there. Nothing bad per se, but it's not something that looks nice. So we try and avoid that.
Right, and we oftentimes, when we're using skin-directed therapy with topical corticosteroids, we'll give a patient 2 prescriptions. So we might give them something from the top of the list, what's considered to be a class 1 or a strong or more super potent topical steroid. And we may have them use it twice a day for 2 weeks. Then they put that tube away, and then we give them a mid-strength topical corticosteroid. So similar to the fluocinolone that this patient mentioned, might have them use a mid-strength agent twice a day for 2 weeks, and then they go back to the strong. And they do that over the course of maybe 2 to 3 months until we no longer see evidence of the disease. And the rationale for going between the strong and the mid-potency is hopefully to eliminate some of the skin-directed side effects. So some of the aesthetic things that we worry about, thinning of the skin, dilated blood vessels, but also to diminish the possibility that the patient will get resistant to the molecule, so they'll no longer get bang for their buck out of the agent. We want them over time, particularly for early stage disease, as this patient online has, we want them maybe to be able to rely on this very simple step 1 ladder approach over the course of a lifetime. So that's what we oftentimes do with topical steroids.
I wanted to make a comment about the Velcro. We used to use the Velcro, the nitromustard in ointment historically. There was historically ointment and water. Nitromustard in water is very unstable, so that if you use it in water in the old days, you had to put it on very quickly. The ointment is greasy, but the drug is relatively stable there, but it was made compounded and very hard to access, and that's where the FDA-approved Velcro came along. The efficacy, as you know, the Velcro, although it's in 1 strength, seems to be, in our hands, more equal or sometimes more effective than the compounded ointments that are higher in percentage. So we do get asked that patients would say, well, the Velcro, it says 0.016 or certain percent. Isn't the 0.04 more that you can compound more effective? Well, that's not a head-to-head direct comparison because the vehicle is different and one is more tested and purified in a FDA-approved packaging. So, and the compounding is not regulated. So we have found patients that they would go to one compounding and the drug works at the same strength and it may not work in another strength. So I think the quality of the compounding is just not monitored, and that's where the FDA approved product has an advantage. As Warren mentioned, that the study for the Velcro showed that there is some significant irritation, and everybody's aware of that. So although it's not in the package insert, the way we use the Velcro is and this is where if the steroids are not giving good results, then we would consider Velcro. Or if you have it very widespread, where it's really hard to use class 1 steroids all of the body, then we would consider Velcro. And we actually we have now an instruction. We start the patients with just once a week. So I don't know, I would love to hear how we do it. So we have a smart text or a little instruction sheet that says, use only once a week when you start the Velcro. And then every week you increase the frequency. So the next week you'll do twice a week, then 3 times a week. Eventually you build it up to once a week. When we've done it that way, we've had much less the contact irritation. And obviously you need to study to do this, but it's kind of individually desensitizing and kind of make it more tolerable. So we've done that, and in case you're about to start, consider that. And if there is some level where it's irritating, we would kind of hold it at that frequency or roll it back, and may have the patients use a steroid on the non-Velcro days. And then if we kind of do that combination, we found that it's better tolerated. It's pretty amazing because like arm could tolerate, but like the trunk cannot, so different body sites may have different tolerability levels. So you can use the Valco more frequently in areas you tolerate, but in the areas you have problems with, you may have to modify the use. And to just one other question, there's great survival data which we show with the stage 1 patient. All those patients are receiving some treatment, even topical steroids. So some people ask, if the outlook's so good, you're going to die from something else, why am I bothering with any treatment? And we usually tell patients that all the great data with large sample size are generated with some treatment, even with steroids, and there is no huge body of evidence that if you totally ignore it, you will be in the same state as those patients who had minimal treatment. So that's why the guidelines don't have no treatment as an option. With some cancers, there is a choice, like observation, like watch and wait. And MF, even the mild state, we don't have a choice of watch and wait because there's no good body of evidence. And we get that question a lot, so I just wanted to kind of throw it out.
I've heard a lot about early stage, such as 1A MF, going into remission. Can you tell me what is the likelihood of that, and how would you know that you were, and would you do any treatment at that point?
So with 1A, it's hard to ever call someone in remission because we know that this can come and go. While we use that term for other cancers, I tend to try not to use it for mycosis fungoides. The best analogy I have for it is telling my patients with stage 1A, think of it like an eczema. Eczema never completely goes away. There are times it's going to be there and times it will not be there, and when it's there, we will treat it. So that's how I tend to look at it. Same as with psoriasis. There will be times that it's there and you treat it, and there'll be times it's not there. So with my patients, even with stage 1A, I will follow them and still say, you still need to see your dermatologist once every 6 months or once a year, even if you're seeing the same stage of disease. And then also tell them if you start to see more than what you normally see, that is something where I think we need to reevaluate the situation and see if you're progressing. And very often, you as the person experiencing the disease are going to know that something is different before I do. And being in close contact with your doctor and telling them your symptoms, if the rash is changing, progressing, meaning involving more of the skin surface area, is important for us to have a clue to move forward in a different way.
I just wanted to add, in terms of likelihood of getting worse, I think that was one of the questions. If you have there are certain subtype of patients histologically, if you're the folliculotropic disease where it involves the hair follicle. So if you look at the published international data, the patients with stage 1A, it's obviously the death is another endpoint. Like it's not going to affect survival. But whether your likelihood of you get to be more than 10%, likelihood that increases if you do have that folliculotropic or other type of variants that have a deeper component. Whereas if you have a very superficial, the common type, then you more likely not progress as long as you keep your skin controlled. So it's just that those patients with a deeper involvement has just slightly higher likelihood of getting worse, but it doesn't mean you will die from it. The survival is very different, so it may get more than 10%, but that's still very manageable.
Right here.
But if the romidepsin or when the romidepsin or whatever fails, you said there's a lot of other things, there are other things in the pipeline. What's in the pipeline that you're really excited about?
So, romidepsin especially works really well for Sézary patients, but it could, but it definitely could work for other stage of disease. So in Sézary, the mogamulizumab, which is in the phase 3 level. And unfortunately, I wish it was available to our patients now. Since the trial closed, there's no way you can get it unless you go to Japan. We did have a patient who went to Japan to get it, but in the U.S., they don't even release it for compassionate basis because until the FDA makes a judgment, they don't want to do anything to disturb it. So, but once that comes out, I think that would be a very interesting, exciting drug. Now, at this time, there are very different ways to use the CAMPath. I don't know if you use the CAMPath. I know that Mariana would say something about it, but in the CLL literature, CAMPath was used a little bit more aggressively, so that you use like 3 months of the higher dose. But again, in Sézary, we use it much less, where that doesn't cause infections. So in CLL, if you use it in the regular dose, you predispose yourself to infections. But the way we use it in Sézary, we use like very low dose. Like we use like, start with 3 milligrams. In CLL, use 30. We use 3 milligrams, not more than 10. And we use it subcutaneously, like an injection rather than infusion. Sometimes it just takes even a couple of weeks for your Sézary counts to come down. It doesn't work as well for the skin, but for the blood, it's definitely highly effective. And you don't get the infection risk like the CLL. So we may use that too, to bridge between, like to transplant to other things. And then some of the newer drugs are not at the level of use yet, but you definitely can combine immunotherapy. So Dr. Abdullah knows that we've been trying to use, with Dr. Abdullah's center too, like the low-dose total skin with like immunotherapy for Sézary patients too. You can just use targretin with interferon. So like the targretin combined with interferon is a good combination for Sézary. Methotrexate, their old friend, use alone, but with interferon. Also can cause some synergistic increase in therapy. So we start with methotrexate, but we would add interferon, then it could boost effectiveness. So there are a lot of other things you can do with the standard therapy, even before the newer ones do come out. And then if you do have access to trials, I think it would be nice if you do participate.
I was going to say, and photophoresis. Gina, we've got an online question.
Gary in Utah asks, I have always been in remission for a couple of years now. My wife is always watching for any new marks on my skin. Once in a while, a small red mark will appear in my skin, usually my upper arms, and it will be there for a few days before disappearing. They don't seem to stay. Should I be concerned? Lack of insurance coverage means I don't run to the doctor at every new mark. The size of the red mark, by the way, is about the diameter of a dime.
Well, I guess I'll take that. So that's not an unusual story that we're hearing. And I usually tell patients that that I have the privilege of taking care of for many, many years with what sounds like early stage disease, is that, let things set up shop. I'm not asking for a shop to be set up for months at a time, but a lesion that is transient, that comes and goes over the course of a couple days, I usually tell them, the skin does stuff like that. I mean, the skin's, there's a lot of immune activity going on there, and a lot of it's good stuff. But if a patch or a plaque sets up shop for a couple weeks and you're kind of looking at it, it's stationary, then that's the time that I would either begin, they may call me and I recommend treatment over the phone, or they come in and we take a look and make sure that it is indeed recurrent disease. So not to panic for transient lesions that come and go. Did you have anybody else?
I think we all agree.
I used Valcalor for about 29 days every day, which was prescribed, and I ended up with deep burns on the areas that I used it. And according to my doctor, I stopped, and he determined that I had an allergic reaction to it. And thankfully to Silvadene, they all healed in about 3 or 4 months. Had I started with the Valcalor once a week, as you just talked about starting that way and then gradually increasing it over time, would I still have had the allergic reaction as it was?
It's hard to say.
There are two common problems with topical nitrogen mustard. One is that it can be irritating. And if it's irritating, the frequency and amount that's used are directly related to how much reaction you get. The other possibility is that you develop an allergic reaction. And that can happen after any length of time. And that can be painful. It certainly can cause blisters, but it also often has a component of itching. So if it's only painful and erosive, it's probably an irritant reaction, and so using it less often might not have caused it. But the thing is that at some point, anyone may develop that kind of reaction. It's a sign to back off. If you stop and it continues to worsen over several days, and particularly if it's itchy, the odds are you may have become allergic. With the old compounded form, we had a standard way to desensitize. There isn't an accepted way to do that now, but I've managed to do it in a couple people. Yeah. Just a way of diluting it with something so that we try and get in under the radar of the immune system and get it to handle without overreacting. But you know, everybody's reaction to topical mustard is their own, and sometimes, frankly, it's hard to tell exactly which it is. But generally, what you do is stop, let it recover. I mean, you were off for 3 or 4 months, but usually we hope people stop when it starts. Let it calm down, try it again. If it comes up immediately, it's probably irritant. If it restarts after a couple of days, it's probably allergic, and if it doesn't happen at all, then we just gradually phase it back in. But what it does and how fast it comes back is some help in trying to decide what options we have.
My doctor had me do a patch test after I stopped using it just to determine for sure that it was an allergic reaction. And I did the patch test on an area that wasn't affected, and you know, the same thing happened. So he said, well, then that was probably an allergic reaction.
Well, I mean, my sense is a patch test, you're placing a substance at some concentration under occlusion. Occlusion always increases penetration. So whatever it was concentrated at, it's actually stronger under the occlusion. And you can have an irritant reaction or an allergic reaction to a patch. Just with standard patch testing, there are some things that we believe are irritant reactions rather than allergic. So again, the timing, the type of reaction. Again, the itchier it is, the more likely it is to be allergic. The more immediate. If you put a patch on and that day it gets red and irritated, that's generally irritant. If it's itchy and red 2 days later, that's more likely allergic. And then anything in between becomes increasingly harder to figure out which, or maybe it's a little of both.
Thank you.
Yeah, I mean, I want to say, I think it's hard to do patch testing to sort out if you're truly allergic unless you have tested a way to do that. Not with the Velcro you have. By putting it on, there's no way you could, I think, tell it apart. But I think it's still worth trying to do it really infrequently. And again, certain areas react more than the other. So even area that you tested the result may not be the same as other places. But it's one of those things that you have to play with. And you may have to use steroids on those days that you don't use a Velcro. But after a while, if the life quality is so negatively affected trying to figure this out, then it's time to move on, definitely to another treatment.
Hi there, and thanks for everybody being here. So over the course of the time that I've been monitoring my disease, it's been probably 10 years, I've asked this multiple times of various doctors about passing this on to children, right? And they're kind of like, no, this isn't, this isn't genetic, that kind of thing. However, I have several daughters, and my youngest is 3, and she's starting to show eczema type of things on her hands and that kind of stuff. At what point do I sort of become concerned to kind of say, we need to take this in potentially to a specialist to get it reviewed for, and it's, just kind of a worry. So I'm just kind of curious what you guys think about that.
So I would say it's definitely something that I think you should probably have a dermatologist look at, because we see more of these rashes and can hopefully differentiate between the two, although it's tough to say without seeing. But I think just even for peace of mind to have someone look at it that knows what mycosis fungoides looks like versus eczema. You're right. It is this is not something that we know of at this point to be genetic, and haven't seen this passed down in multiple of our patients. So I think it's definitely on the lower side of worrying about it. And children definitely tend to develop eczema, and eczema is a big mimicker of MF and vice versa. So I think it's something that, common things being common, we would favor more that it's probably not mycosis fungoides, but better just to have it checked out for your peace of mind and your family's peace of mind.
Thank you. So guess what? It's lunchtime. So I will give you one last shot if anyone has a question they'd like to ask our esteemed and wonderful and amazing panel, or is everybody starving and we're going to go out to... Oh, we have one more question. Tina's right behind you. So we'll take one more.
I have follicular MF, forehead, and it's been a resistant spot. We've done low-grade radiation, photon and electron beam. We've tried Aldera, we've tried topical things, and we're trying Targretin right now. And I just started it last Saturday, every other day, just on this small portion here. I went to light treatment on Wednesday, and it really became inflamed. I used it again on, and I'm seeing my doctor in Chicago on Tuesday. Is that sufficient for right now, or should I call and say this is inflamed and what's going on? No comment. It's tough. I don't know,
Topical retinoids of all kinds, which Targretin is one of them, tend to be very irritating.
Yes.
And then light tends also to bring out, if you have mild redness and you put ultraviolet light on, it's going to get more red.
And
so it's certainly most likely a sign of irritation, maybe even of a little bit of effectiveness. The question is, if it's really uncomfortable, then you may want to modify it. But if it's simply a little more redness, hang in there and see how it goes.
Right.
It's a little too early to know what the
on?
topical is going to do.
And I didn't have light treatment the first few times I put it on, and we're only leaving it on for 1 hour, so it's not like we're leaving it on for a long time. But it just became inflamed. The first 3 times I put it on for a little longer than that because there was no irritation but no light treatment, and the light treatment was only 30 seconds, so 30 seconds of my whole treatment.
I always feel like if you've seen one patient with MF, you've seen one patient, because everybody's disease is a little different and everybody's reaction to treatments are a little different. And so I always think of it as sort of a co-discovery.
Yeah.
We're going to have to see over time what your version is doing and how it's reacting, what your reaction to treatment is.
As I call it, a work of progress when you
Right.
have follicular, that it's not as easy. CTCL is rare, but the follicular even rarer, so,
And the only other caveat that I would add to that is sometimes seeing a little bit of an irritant or an inflammatory reaction ain't a bad thing, because sometimes that
means
cells
it's
kind of
working.
getting where they need to get to, and that's true for the Valchlor. Sort of getting back to that question online, for a lot of my patients, they'll get a little bit worse before they get better, and they have to understand that and be prepared for that. So, together you can kind of monitor the response. So, for Valchlor, oftentimes my patients may apply it in one area and they have some disease that kind of comes to the forefront that wasn't there before therapy. So they need to know that that's potentially an expected response for them. And that's true, it sounds like, of what you're describing here. So it's not necessarily an adverse event, but something happening.
Thank you.
Add to the follicular tropic, because the follicular tropic patients do have a little higher chance of it getting worse over time. After the topicals have been tried, I don't know how extensive your involvement is, but let's say we try different topicals, and whether it doesn't work or you just can't go over the irritation factor and you just can't use it well, and then you would have to think about, obviously, some low dose of some systemic agent to control it. Targretin used orally in conjunction with light therapy, rather than trying to use it topically, which may add to the irritation, but maybe working better if it's systemic, so that the deeper part of the hair follicle may get addressed better. But again, if you combine it with light, you can get away with very low doses of the pill where you don't risk yourself to the lipid issues and the thyroid issues, but you can partner it well. So things like that.
Thank you.
Thank you. All righty, I think it's time for lunch.